This is the case. The patient was 17 years old, has a progressive deformity, had back pain. The neurological examination was normal. Patient's clinical photograph. So, who wants to talk? My friend, what do you think? Can you give microphone?
Say
This
left shoulder is upward and right shoulder is downward.
Wait. This is not shoulder.
Oh, this
is scapula and also the quads. Look. If you draw two lines here, okay? You're right, there is a shoulder imbalance there, but it's not important. But to decide one of the, as Zilili told, deciding the levels for fusion is important thing. Commonly, okay, if you're operating a patient and if the patient's left shoulder is depressed, you have to go to T2. If patient's shoulders are balanced, T3 is fine. If the left shoulder is elevated, usually you have to go to T2. But commonly, if they're balanced, T4 is enough. Another point is that you have to look T1. In this case, the T1 is also tilted. So you have to go to upper part. The question is that, do we have to operate them? Do we have to left them, go to the, can we say that go to the physiotherapy? Look at the, here, look, this is the lung. And if we operate them, what do we have to do before the surgery?
Pulmonary function tests, evaluation of cardiac evaluation.
You're right.
Nutrition is very important. Nutrition from this.
Another point is that
I think it's very important. Physiotherapy is very important if you want to build them up. And if you build them up and their pain goes away, I'm not sure if I would like to operate here in the first place. Second thing is obviously you need to have a look at their CT, and we can't see the pelvis very well over here. So you need to look at that. You need to look at, is there any neurological abnormality to go with it? So it has to be the whole package. You just can't decide on the basis of x-rays.
Look, this is a congenital case, but under it, it has to be some syndromic.
Yeah.
Because look at the length of the arms here. Also, if you look, we had also the leg films. One of the leg is shorter than the other one. First, I told him we have to operate the leg, but he was focused on the scoliosis. He didn't want any leg operation. He came, please operate me if you can. In these cases, especially renal and cardiac abnormalities will be in that patient. So you have to check. You need a pediatry and also cardiology consultations. Nutrition is very important. You have to get the pulmonary functions. In some cases, they don't allow you to do the surgery. Salman, I will show a little video, okay, after that, only 1 minute. I will tell what can you do in that cases. So what we have done, the patient had also sorry, I would say that, look, in Zilali's case, the curve side was on the right side, but in this case, it is on the left side. It shows us it may have any intramedullary problem there. So we get an MRI for that patient. First of all, we saw that the patient has a tethered cord. We operated first. If you look only to the curve, okay, you may say that, look, this is not a good surgery. Our friend is not here, as a classic neurosurgeon, okay? This is not a perfect surgery, but believe me that the thing that you didn't like is not the thing that I liked. If you look only to the curve, you may say that you couldn't correct that patient. Before and after the surgery, as I told before, no patient can see inside, okay? The patient is dealing with the outside. So we applied posteo-osteotomies here. We resect ribs here. Look at here. Look at the lung after the surgery. If you look, that's what I didn't like. So maybe going to iliac wing will solve the problem, but the leg discrepancy, the correct procedure has to be first the leg operation, then but patient refused it. So this is the X-rays. But if you look to the clinical photographs, this is the change. We applied ponteosteotomies here. We resect the ribs. One of our physiotherapists is talking about 3D dimensional correction maneuvers. He says that the muscles are so weak here, and if we get exercise on that side, we could bring the muscles symmetrically. He could do it with 15 days with nutrition. This is in front of the front view of the patient. Look at the, yes, and also see the asymmetry. The patient is not releasing the asymmetry now. And if you see, the kyphosis has disappeared. Another technique during the surgery, look, this rod is not parallel to the rod, this rod. I used double rod here. You have to push down the convex side, push the convex side to the medial, and also using this double rod will decrease your kyphosis. If I turned this domino a bit to the laterally, it will be perfect here. And in some cases, the anesthesiology doctor doesn't allow you to do the surgery because of the decreased pulmonary functions. This is hollow. These 3 patients couldn't be operated because of the lung problems. I've seen this hollow traction on a YouTube video. I've designed it. You see there is no load here. It has a double system. These patients are using this hollows while they're walking, sitting and lying. And in the literature, it says that if you use it for 1 month, the pulmonary function will increase 20 or 25%. So we could operate that patients using this hollow system. It's like Istanbul's traffic. Patients are walking in the corridors. Any questions?
In cases in which scoliosis is associated with cord teething, which procedure you do first? You untether the cord and then correct it?
Yes, this is a good question. If the patient was 5 or 6 years old, okay, first of all, you have to do the tethered cord. Then you may follow the patient, but you cannot follow this patient, okay, because it's a severe curve there. Retethering the spine will not correct the curvature.
Are there chances that if you re-tether the cord and then do the correction,
Mm-hmm.
later on he may develop some symptoms of teething again or not due to manipulation?
No, there is no knowledge in the literature. It will not retether again.